Tuberculosis is a deadly infectious disease caused by Mycobacterium tuberculosis. Currently, 1/3 of the world's population carries some form of the tuberculosis infection. The disease burden is high in developing, impoverished countries such as Southeast Asia, Eastern Europe, and Africa, where compliance to drug therapy is a problem. Developed nations such as the United States experience low disease burden due to strict case reporting and adherence to efficacious drug regimens. Another thing to remember with TB is that when virulent M. tuberculosis organisms grow in culture, they form a serpentine, meaning snake-like pattern. This pattern is caused by the mycolic acids that form a complex called cord factor. Cord factor is related to inactivation of neutrophils and can release inflammatory markers like TNF-alpha. Cord factor is related to the virulence of TB. Primary TB begins in the lungs when infectious particles are inhaled from the surroundings and phagocytosed by alveolar macrophages, which you can see animated here. A chronic inflammatory process then ensues, damaging lung parenchyma and forming caseous granulomas made of numerous infected macrophages and necrotic cellular debris. The granulomas are termed caseous because the granuloma has the texture of white cheese when viewed by the naked eye. You can see these granulomas, which are pointed out by the arrow here. On chest X-ray, it may be possible to see the primary site of infection in the lung, called a Ghone focus. The Ghone focus is the primary site of tuberculosis infection in the lung. It is generally located in the lower portion of the upper middle lobe or the upper portion of the lower lobe. The Ghone focus is only visible on chest X-ray if the site has calcified or grows substantially. Another sign of primary infection on chest X-ray is the presence of Ghone complexes. Ghone complexes consist of a Ghone focus plus lobar or perihilar lymph node involvement. You can see the Ghone complex here on the left side as well as on the right. Again, remember, radiographically left and right are backwards. Most of the time, infection is controlled in hosts with intact cell-mediated immunity, and the host experiences no symptoms from the lung infection. However, TB are not always eliminated from the host. Rather, they can remain in a viable but dormant form within granulomas, ready to be reactivated at the first sign of immunodeficiency in the host. Buckle up, folks. We're about to go for a ride. If you are a person with a normal immune system and you get exposed to TB, how can I diagnose that you've been exposed? The answer is that we would place a purified protein derivative, or a PPD, skin test and look for a reaction. Whoa, there is an immunology correlate coming. What type of hypersensitivity reaction is involved in the PPD test? The answer is type 4, or delayed type hypersensitivity reaction. Okay, so back to our healthy exposed patient. What type of TB does this person have? You would call this latent TB because they're actually asymptomatic. Oh, and by the way, for a normal individual with no immunocompromised state and not involved in the healthcare field, how big of a PPD in duration is required to call it positive? The answer is 15 millimeters. 15 millimeters for just your average healthy person. So if you're healthy and not involved in the healthcare field, 15 millimeters. Now, what if that person works in the healthcare industry? Well, in this case, the answer is 10 millimeters. Okay, 10 millimeters for med student. Med studs, 10 millimeters. How about if the patient is immunocompromised, like an AIDS patient? Well, in this case, the answer is 5 millimeters. So AIDS, 5 millimeters. The reason is that in immunocompromised patients, because they have less immune cells floating around, our threshold is much lower for calling a reaction positive. They may not be able to mount an immune response strong enough to create an entire 15 millimeters of induration. Keep integrating that immunology. Let's go. All right, so our patient has a positive PPD to 15 millimeters. What is the next thing you want to do? I think we should get a chest x-ray. What do you think? Okay, let's order a chest x-ray. Chest x-ray is negative. Great. So we don't need to treat our patient, right? Wrong. Positive PPD and negative chest x-ray is diagnostic of latent TB. So what is our treatment regimen? Isoniazid, abbreviated as INH, plus vitamin B6. Farm integration coming. Why do we give vitamin B6? Isoniazid can cause B6 deficiency, so you might see symptoms like neuropathy. And while we're on the topic of isoniazid, what lab tests do you want to keep an eye on? Their liver function tests, their LFTs. You're definitely going to want to check the LFTs because isoniazid can cause hepatitis. So you're going to want to follow their AST, you're going to want to follow their ALT closely just to make sure they're not developing drug-induced hepatitis. Whoa, I hope that was fun. I know this is a micro lecture, but I want to get you points in pharm and immuno and path as well. Love it. Let's keep moving. Reactivation of dormant TB can lead to secondary TB when the host's cell-mediated immunity is compromised and allows for escape of the organism from granulomas. Secondary TB commonly affects the apices of the lung, as Mycobacterium tuberculosis has a predilection for the high oxygen concentration found there. You'll learn in pulmonary how the apices of the lungs have higher oxygen levels. This chest x-ray shows a patient with advanced tuberculosis. You can see the cavitary lesion in the apex of the right lung. Symptoms of secondary TB can include fever, night sweats, weight loss, and hemoptysis. These are the classic symptoms that you hear about when people refer to TB. Reactivation of tuberculosis can also affect organs other than the lungs, such as the kidneys, GI tract, and the lymphoreticular system. CNS or the vertebra can even be involved. TB affecting the vertebra is known as Pott's disease, P-O-T-T-S, Pott's disease, and can lead to compression fractures. Rare complications of primary TB can include miliary tuberculosis or even death. Miliary TB occurs when TB gains entry to the blood and then spreads throughout the body, seeding various organ systems. Note the tiny little pulmonary nodules diffusely located within the lung fields. You can see these tiny little white dots everywhere. Fatality in disseminated TB is nearly 100%. Can you believe that? 100% if untreated. Death occurs in hosts who are severely immunocompromised at time of primary infection, such as malnourished or HIV-positive hosts. Flash quiz. Okay, so now you're working in the emergency department and a 32-year-old male presents with nausea and vomiting over the last hour. The last time he ate was about 4 hours ago, and what did he eat? Leftover steamed rice. There's your clue. So, what is your most likely diagnosis? The answer is Bacillus cereus, which, remember, activates when rice is reheated. Mycobacterium tuberculosis is the most important of the mycobacteria. It is a small, non-motile aerobic rod with complex cell wall composed of lipids called mycolic acids. They are also known as acid-fast bacilli, or AFBs. Can you remember two other organisms that stain positive with acid-fast? Those would be Mycobacterium leprae and Nocardia. The mycolic acid cell wall is responsible for the ability to use acid-fast staining to identify Mycobacterium tuberculosis as well as other mycobacteria. Tuberculosis will appear red because it resists decolorization by acids during the staining process. The mycolic acid in the cell wall prevents the dyes used in the gram stain from entering the mycobacteria, so they do not stain in the gram stain. Do you remember what other bacteria is acid-fast? We just talked about it a few seconds ago. The answer is Nocardia. And what did I say was the antibiotic of choice for Nocardia? Oh, snap! For Nocardia, it's going to be sulfonamides. There are a few other species within the Mycobacteria family that you should be familiar with. Mycobacterium avium intracellulare, MAI, is commonly tested on the board since it is associated with AIDS infections when the patient's CD4 count drops below 50. It primarily causes pulmonary infections leading to disseminated disease. So, you're following your AIDS patient CD4 counts and you note that the latest number was 48. You're concerned that your patient might develop MAI. What antibiotic do you want to start right away? Patients with AIDS should be treated prophylactically against MAI with azithromycin as their CD4 counts begin to drop below 50. Azithro. Mycobacterium kansasi is very rare. It causes symptoms similar to Mycobacterium tuberculosis. Another Mycobacterium species that is sometimes tested on the boards, Mycobacterium leprae, causes the disease known as leprosy or Hansen's disease. Leprosy is a granulomatous disease affecting the peripheral nerves and skin. Left untreated, it can cause permanent damage to nerves, skin, limbs, and eyes. This is an image of a patient with the characteristic leonine or lion-like facies of leprosy. You can see that he has the thickened, nodular facial skin, as well as the saddle nose deformity, and that's when the bridge of the nose collapses. Because it affects the superficial nerves, leprosy can cause a loss of sensation. There are two forms of leprosy which are differentiated based on how good the immune response is. The first is tuberculoid leprosy, which occurs in patients with strong, intact cell-mediated immunity. That's high CMI and high Th1 cells. These patients will present with a few hypopigmented macules that have complete sensory loss in and around the lesions. They will also have skin granulomas, indicative of a vigorous, intact inflammatory response against the bacterium. Tuberculoid leprosy is usually self-limited, and the infectivity of the skin lesions is quite low, owing to the fact that there are few to no organisms living within the lesions. Lepromatous leprosy, on the other hand, is the more severe form of leprosy that can occur in immunocompromised hosts with weakened T-cell immunity. That's low CMI and low Th2 cells. These patients will present with nodular growths and thickening of their skin that compromises underlying tissue function. These patients will also have peripheral neuropathy. Note that Mycobacterium leprae is not diagnosed by culture. Instead, an acid-fast stain coupled with PCR assay is typically used in diagnosis.